Please welcome to the stage our speakers and session chair, Dr. Ed Piper, Director of Medical and Scientific Affairs, AstraZeneca, to discuss innovating today to progress care, quality and outcomes.
Come on out. As you can tell, that wasn't the introduction I was expecting, but good afternoon to everybody here. Thank you for joining this session, Innovating Today to Progress Care, Quality and Outcomes. And I'm Dr. Ed Piper, I'm the Medical Affairs Director at AstraZeneca UK, and I'm absolutely delighted to be joined by Professor Gary Ford, CEO of Health Innovation at Oxford, and Lisa Gallagher-Dawson, Director of Performance at Greater Manchester Cancer Alliance. And we're going to run this sort of as a panel session, picking up on some really interesting themes and questions, which we're going to get Gary and Lisa to give a view on. And we think this session is incredibly timely. Our healthcare system is under unprecedented challenge that we're all aware of. The ONS is predicting that almost 10 million people across England could be waiting for an NHS appointment or treatment. The Health Foundation is busy forecasting that 9 million people in England will be living with major illness by 2030. So the challenge is unprecedented. On the positive side, the speed of innovation that we see in life sciences is really accelerating. And I think we're in an age where rapid scientific discovery being translated into innovative medicines is really on the cusp of some great things. And at AstraZeneca, you can imagine that R&D innovation underpins our whole business. And we have a very bold ambition that by 2030, we'll have introduced 20 new medicines to the market. And at the same time, our organization will be carbon negative. But I don't want you to think about innovation being the preserve of R&D and academia. Every day, we at AstraZeneca are absolutely privileged to work with healthcare professionals across the NHS who are innovating in practice today. And that's what this session is all about. Because when innovative medicines that we have in our hands today are deployed in clinical pathways, supported by cutting-edge digital and data tools, the potential to improve outcomes for patients, I think, is clear to everybody in this room. And the impact of some of our innovative partnership programs give us huge confidence that that's true. I just cite three for you to get us going. We have a pathways optimization program in Glasgow in heart failure called OPERA, and that program has delivered improvements in heart failure diagnosis, which were taking upwards of a year all the way down to 6 weeks. The partnership, which Lisa knows very well, with the Greater Manchester Cancer Alliance, using an AI platform to interrogate chest x-rays to diagnose lung cancer earlier. And lastly, possibly our premier scaled partnership program called Sentinel, which was designed in Hull and was shown to reduce asthma attacks by 30% and to reduce the carbon footprint associated with excess use of short-acting beta-2 agonists, has now been adopted and scaled across over 300 PCNs, which is great news for the system and patients with asthma. So those examples and many others I could cite really do exemplify the power of innovative approaches to care. So we're going to discuss between us how the NHS can support and drive that culture of innovation even more deeply. So I'm going to start off with the first question, which I think goes to you, Lisa. In your opinion, what types of innovation do you think offer the greatest opportunity to improve patient care and outcomes?
So anything that delivers more rapid access to diagnosis and treatment without doubt is something that our patients would feel very passionately about. And I guess it depends on your circumstances, because if you are a patient, those will seem the most important. But actually, earlier in the pathway work, population health, and I think our biggest opportunity currently is probably in the digital field.
Very good. And I mean, undoubtedly, diagnosing lung cancer earlier is huge priority to the system, and the potential to impact by getting curative treatment in earlier is massive, I think.
It's life-saving.
Yeah.
So the difference between those time frames can be the difference between curative and palliative treatment, and that might mean an extra few years at home with your family. That might be living better quality of life at home whilst you are suffering disease burden.
Absolutely. Gary, thoughts on greatest...
Yeah, I mean, just to add to Lisa's comments, I mean, we've got a lot of highly effective, high-value treatments that aren't getting to all of the patients who can benefit. I mean, this is a challenge for all healthcare systems. So innovation, which makes sure people get the best treatment at the right time, as early as possible, is what adds your greatest value. And a lot of that is in relation to diagnostics, as Lisa's mentioned, pathway transformation, digital tools that support patients. And it's really important to think about that type of innovation, which also addresses the major challenge to the NHS, which is the workforce problem. So how do we maximise what our workforce can deliver through innovation?
Very good. Any thoughts about how that can happen, how innovation can offset some of the capacity challenges that...
Yeah, so I mean, if you, for example, some of the innovation is pretty much still at the research stage, for example, online cognitive behavioural therapy, diagnostic assessments for children and young people with mental health. There's a lot of that sort of work that allows you to remove some of the waiting list by earlier diagnosis. It allows you to replace, as long as you've got a good evidence base, obviously face-to-face therapy, where we will never have enough workforce to deliver with that model. And then I think if you organise the pathways so that patients go through a minimum of healthcare professionals to get to where they need to be, through better diagnostics and signalling, that again gives you major workforce benefits.
Yeah, and that's exactly our experience with the Opera project I mentioned in heart failure. It's exactly that. It's smoothing the pathway and reducing the friction that sometimes is in there. Okay, well, let's move on and say, so innovation is fantastic, but we all know it's one thing to say innovation, it's entirely different to actually make it happen. So there are some barriers, aren't there, Lisa, and challenges to innovation in the NHS. Maybe a comment from you about what you see as maybe the one or two biggest challenges, and then how they can be overcome.
Sure. So I think that some of the main barriers is having to be able to demonstrate evidence. So being able to talk to those that are the decision makers around delivering innovative solutions, expanding those across populations, different disease groups. And that's challenging in a situation where quite often the funding for NHS projects is an annual cycle, and quite often innovation takes a longer time. So that can be one of the key barriers. And I think being able to demonstrate the impact quickly enough is a real challenge, to be able to then adopt that further or secure that longer term funding. In terms of what we can do to overcome that, I think transformational fund approaches are really good at being able to get things off the ground or hold them whilst those business cases are worked through. I think change agents are really important, bringing together the different strands of the system. Quite often we've got expenditure in one part of the system and savings in another, and actually those two sometimes don't come together. So it's really important that as a system we start to work together, probably using the infrastructure of the ICBs more, to help us navigate some of those challenges.
Thank you. Gary, challenges.
So I'm going to focus the question on the challenge is not the creation of innovation. We're actually, as a health system and an ecosystem, very good at that, both in industry and academia and the NHS itself. The challenge we've got is the widespread and adoption of innovation when it's shown to be of value. And I think there are multiple issues there, but perhaps the main one is to change a service, you have to have some capacity and time with healthcare professionals to be able to think about that and have the space to do it and planet, and that then needs support both from within the organisation and also through wider networking to draw on experience. So there have been effective structures in the past, such as the clinical networks, when they were focusing in cancer, cardiovascular disease, which I think did have a big impact on spreading the adoption of innovation. So in the stroke case, getting more uptake of thrombolysis, better scanning in the pathways back in the 2000s. And obviously the health innovation networks exist as a support organisation to help our partners do that change. But you have to have the capacity and resourcing within the system. And that's very hard when the system and healthcare professionals are under so much pressure. So rather like research, you have to think about how do you create that capacity, because it's in the important, not so urgent box, which is so easy to get neglected.
I mean, sort of building on that and maybe going to our third question, I mean, our observation at AstraZeneca is, you're right, there is so much great innovation that goes on in the system. Clinical enthusiasts find solutions to clinical problems that they are passionate about solving. There's no shortage of that, but what we're very good at doing is running sort of pilot projects that show evidence of benefit, maybe in a particular region or locality, but trying to scale that then beyond that locality or that ICS or ICB is a real challenge. And we don't sort of seem to have a systematic way of doing that repeatedly. So I don't know, Gary, would you agree with that assessment, or have you seen examples where in fact scaling can happen? And
I think we've got examples where it has been successful. I think your observation is correct though. I wouldn't disagree with it. You do have to have support for implementation. You do have to have some experience with, we would call real world evidence of the innovation, service change being introduced into a pathway in enough settings. So that's usually more than one organisation, but it's not 20 pilots you need. And the problem with a lot of the pilots is they don't do very good rigorous evaluation, which is what you need. So if you're going to do a pilot, you've got to think, okay, what are we going to measure and learn from this that would make it adoptable elsewhere? So that means you have to think about other people as well as yourselves when you bring it in a service. So we would then look to have enough experience that we can then produce an implementation support pattern. We've worked through, okay, who's going to pay for it? What type of healthcare professionals can deliver this? What change do you need? What patient engagement sort of approaches do you need? So a successful example was a diagnostic placental growth factor, which was a research project in a couple of places in the country. Obviously with a commercial partner, this is to diagnose preeclampsia. My team helped get that into maternity units across our, as it was, AHSN region then. So we learnt a lot from that about the practical factors to deal with. And then it became a rapid uptake product nationally and was supported by all the health innovation networks and the maternity networks. And that got adopted very rapidly because I think there was a clear approach and thinking about it. You do need to identify your champions. I mean, we produced in the workstream 1 in the Synca review, which it will come out soon, a set of the 9 hypotheses, principles you have to follow for national spread. In contrast, I'll give an example, the diagnostic Pheno, which you'll be familiar with, Ed, for asthma, was recommended by NICE in 2014. It just didn't get adopted at all. We then, Wessex HIN then took that on again with national support for funding, and that actually spread very effectively over a number of years, having been flatlining for a while. And that was quite important as part of the asthma pathway and in thinking about how people get to the right place for their asthma care. So I think we've got some examples of where things have not been in place and it doesn't happen. But innovation doesn't get adopted just because NICE issues a guideline that it should be, and I say that as a non-executive director on the board of NICE.
Thank you. Lisa, anything to add to that?
Thanks, Ed. I think we've had some really positive experience of spreading innovation through the Cancer Alliance. I think they are generally seen as vehicles for change, which is good. It's not plain sailing, that's absolutely for certain, but I think in particular, the Greater Manchester Cancer Alliance has been fortunate to have some absolutely fantastic people working for it that are well renowned for their innovative approach. And I think that some of that passion has really helped catalyst some of that adoption. We've had a number of programmes in Greater Manchester, so the Cure Smoking Cessation, the Nostalgia Pathway for Breast Pain, targeted lung health checks, which were born in Greater Manchester and have been adopted. But it's not uniform, it's not one mechanism to do that. Some of that comes down to the passion and the tenacity, I think, of some of the individuals. I would agree that we don't have a roadmap. I think that's something that we ought to have and we could do more of. My experience is that we've got a number of other things that we can't get adopted just because they haven't got enough of an evaluation, they're not well enough embedded to prove the longevity of them, but they're exciting things, and actually we don't have that roadmap other than to keep banging the drum sometimes. I guess organisations like GIRFT that are now getting more involved in my area of expertise, which is cancer, they are starting to take an interest in those kind of innovations. But I guess that we need to work collectively across industry, across the NHS, to be able to provide that more seamless roadmap. We spend a lot of time in the NHS, I can say that as an NHS employee, describing how different we are and why something might not work in our area. But actually we need to look at what similarities we have, not just the differences. I don't know whether some of that comes from those of us that have been around long enough to be in a competitive environment. It was competition rather than collaboration. But we're in a different place now, so it's about learning from each other. It's about working together. And actually, this should be about the patient. And if something is working, why shouldn't it be working for everybody?
Yeah, that's brilliant. I mean, so often we focus on the evidence, and we always say we need to have clinical evidence of benefit of an innovation. We need to see that it's cost effective, and we need to have patient input to see how it felt for the patient. And we start with those things, but often we sometimes forget the importance of culture that you're bringing into that as to why you've been successful in your organisation. I mean, the cultural aspects of this we could probably talk about for the rest of the afternoon, but they are essential and not to be forgotten about. Okay, thank you. So let's shift gears and tack a little bit about something that we're very passionate about at AstraZeneca. And let me try and explain to the audience. In many ways, we see all too often clinical research here, and we see clinical practice here, and both innovate really strongly, but we far too infrequently see the two sort of come together and to find ways to bring innovation in clinical practice and innovation in clinical research together. And I think that's incredibly important if we can try and crack that nut. So Gary, I wonder if, again, do you agree? Have you seen examples of where that happens, and any thoughts about how we can sort of move forward on that kind of agenda?
I think they often are not linked enough and working together, and that can happen if one has a very linear model view of innovation, that it goes from basic research, through the research pipeline, and then it's handed over for guidelines and then implementation. But for many areas of innovation, it's much more complex than that. Most service redesigns don't start as a research project. They start as a service development and evaluation in the NHS. A lot of tech is developed under a service evaluation type framework and diagnostics, and then you need to do a more rigorous evaluation. So that's a much more iterative approach. But I think more fundamentally, it's really about the NHS signalling clearly what its priorities are, and being aware of what the opportunities are, where there are tractable solutions that could be developed. And I think we're still not as good as we need to be at signalling the priority needs. And these needs in general are not specific disease pathways. When we looked at did a survey 5 years ago between the HSN's work and NIHR, which I led with Louise Wood on the NIHR side, we are senior managers and clinicians, not researchers, what were their priorities. And surprisingly, relating back to my earlier point, the top one was workforce. Okay, so So that's quite important. Do researchers think about workforce? Did I, usually think about workforce when I was thinking about what can I do to improve stroke patients? I didn't think about workforce at all. It's usually just buried in a health economic analysis. So that if you start with that need, that means you have to think about workforce as an outcome in your studies and study it very early on. And then there are priorities everyone's aware of, like mental health, particularly in children, and this has been exacerbated since the pandemic. But do we have enough capacity? Are the universities and the funders taking on enough responsibility to develop the research capacity we need? And they are now, but you often see the misalignment. So then you've got a lot of research in one area, which isn't really a priority for the NHS. That's just historically, that's what's evolved in a particular university department or across universities. The thing that really helps is when you've got boundary spanning individuals, people who are working in both camps and can understand both worlds and work across those. And I've done, I suppose, a fair amount of that between the NHS and academia. But I think there are examples as well between industry and the NHS. So, for example, a colleague of mine spends half his time as a consultant stroke physician, working on stroke service, and he's also chief medical officer for a company, Brainomics, who do straight cut AI imaging. That is really valuable experience when you're then looking to understand how you might get something in. He absolutely understands the service. He doesn't have to go and talk to lots of people about it. I mean, he does anyway, and he understands the issues on the company side. So we talk a lot in the research world about discipline hopping and interdisciplinarity, and I think we do need to think about that as well in our world.
Lisa?
Building on the points that Gary's made, really, I think that that holistic sense of looking at both of those areas and how you bring them together and share expertise is going to be absolutely pivotal. For me, I think some of this is about us looking at things more holistically, understanding that with the best will in the world, research is only of benefit to patients if we can deliver it. And we need to look at that entirety of the pathway with the patient really at the heart of it. So what does it mean for the patient? How do we deliver that change for patients? Because ultimately that's what we're all here to do. We have a lot to learn from each other, and I think that the research and the delivery arms need to come together more frequently, with the patient perhaps as the conduit in between, to really understand what it takes to make it work for both parties.
I couldn't agree more. So penultimate question. We've seen the ABPI and NHS Confederation publish a report this week about the strength of industry NHS partnerships. We're at AstraZeneca are massive believers that collaboration and partnership can unlock phenomenal improvements for patients. So I'd love to hear what your views are about what more we should be doing to foster those kinds of partnerships and collaborations between NHS and industry. Maybe Lisa, why don't you start?
Thanks. There is real benefit, absolutely, but I think that we can do a lot more from both sides. I don't think the NHS is always the easiest to work with. We have so many different policies, procedures, organisational boundaries, geographical boundaries, that it is a bit of a minefield. So I think that we could collectively strengthen, I think I'm going to use the word roadmap again. I think we could strengthen and deliver some kind of roadmap that helps people navigate IG data issues. We're moving into a different world where we've got secure data environments, but even with that, it's going to be a real challenge. So you need tenacity to make it work, and we need to make it easier for people. So overcoming some of those organisational barriers, data sharing agreements, the legal aspects of it. Actually, that's not most people that want to deliver change and innovation. That's not their bread and butter. We need to absolutely navigate that for people to make it easier. Sharing good examples as well, because people want to see that it can work. And
there's some great examples in that report, actually, which is...
There are. It's a really good read. If you've not seen it, then, it's definitely worth looking at. But I'm a firm believer that you can make things work with the right approach, and getting people together that have got a common sense of values, a common ambition, an aligned goal. I think you can make it work, but it's hard. So we need to do more to facilitate.
And on the industry side, the preserve of complexity is not just with the NHS. Sometimes we can be pretty difficult animals to navigate through. And you talk about AstraZeneca as a single entity. In fact, that's a team of number of thousands of people, lots of different entry points for people. So you talk about collaboration, but where and how. So I think we're not perfect either.
No, but we have also got different levels of expertise in different areas, and seeing that that's not equal is a good thing. Us being open and honest about that and using each other's skills to make it better.
Agree. Gary?
Yeah, I mean, we had some rich discussions about this partnership working challenge in the session that Roland Sinker chaired this morning, and I think Lisa's made a lot of the points. I think there's a general view that culture and trust are very important. That's the first thing. There's a lot of, in some quarters of the NHS, distrust of life science companies, particularly pharma, which is I think, to be honest, completely unfounded at the stage of research we're talking about, and a lot of it is historic marketing practices. But I think, emphasising Lisa's point, being clear on priorities and purpose, I think the articulation of the Alliance Science missions is very helpful. So it gives specific areas to think about how, as a system, the NHS is going to work on those with life sciences. Bringing together joint skills around the transactional arrangement, I think, is again very important, because I think there are valuable skill sets in life sciences sector which are different from the NHS, and also the voluntary sector can often bring in value. So I think being clear about the areas of focus, what we're trying to achieve, bringing the relevant skills together, and alignment of objectives, and certainly moving away from focus on any particular product. That generally is unhelpful in getting effective engagement in the NHS. So, if we look at, there's a big commercial deal many of you will be aware of with inclisiran to get, the concept is very good. We want new drugs at high volume, low cost, so the company still makes it the same profit margin it needs to make, but we get more benefit from that. But you can't start a conversation with the system around, we've got this great new drug and we want to introduce it. You've got to start the conversation around, we have a massive opportunity in your area for people who are not treated effectively to prevent cardiovascular disease. And we know there's an opportunity to prevent so many thousand strokes and heart attacks. And this is one tool within that, but we'd like to have a conversation with you about what else can we do across this whole pathway. And there's a lot of things we can do. So you have to position innovation correctly, as you well understand, Ed, with the asthma biologics. It's about, okay, what's the position with care of asthma patients in the area? Are patients getting to the right specialists who need to, and how can we facilitate them?
Brilliant. And I think the other thing from an industry perspective is, don't just think of industry as a source of funding. There are a lot of skills that we have in the industry: project management, pathway redesign, seeking tools to risk stratify and identify patients, services to implement guideline-directed medical care. There's a lot going on, and it's not just a funding stream. So as we come to the end of our session, we're going to land with, you've got a group of people who are innovators in the audience. If you had one piece of advice for the audience about how to further that sort of innovation gene, as it were, what would that one bit of wisdom and advice be? Lisa, you first.
So I think we need to absolutely have patient first, collaborative, not competitive approach, and I would challenge everyone to see whether they think they're being courageous enough with their change.
Gary?
I'll give one sentence. Look outside your organisation for solutions, be bold, evaluate well, and adapt.
Brilliant. Well, look, I hope you've enjoyed the session as much as I have. Huge thanks to Lisa and Gary. Thanks to the audience for coming, sharing your lunch with us. And I hope you leave as positively buoyed up as we all are about the potential for innovation and all that we can do together in partnership to improve the way that the system delivers its outcomes for patients. So thank you all very much. Thank you, panel.